Hey everyone, I'm Samantha Shipp. I'm a student at Campbellsville University. I'm in the MSN program. I'm here with Chris Doolin to do an interview, and I'm just gonna go ahead and start with some questions here. Can you tell me your name, title, and type of practice?
Sure, my name is Christopher Doolin. I am a master's in the science of nursing prepared nurse practitioner with a family degree, and I actually practice in the acute care setting, and I have done that ever since I graduated school. I also have practiced in the emergency room as a nurse practitioner as well.
Okay, so that kind of leads into the next one, the personal history and education.
Yes, I graduated from Spalding University with my master's in the science of nursing with a family focus. And I went to work as a hospitalist directly out of school,
Okay.
which is a little different. Most people don't do that. But I have a very big critical care background, so I was very comfortable doing that.
Right.
Then I moved to the ER and I moved back to hospitalist, which is where we're at now.
All right. So when did you decide to be an APRN?
Let's see, I graduated nursing school in 2005, and I decided while I was in nursing school that I wanted to go ahead and further my degree while I was still in school. So I basically did nursing school for about 7 straight years. I took a month off in between each
Wow.
degree, but I still worked as an ICU nurse while I was actually getting my MSN. So probably sometime right before I graduated my bachelor's, I decided to go ahead and do my master's.
Oh, that's pretty awesome. Let's see. How did you find your present job?
Oh, that's a funny story. I was working in the ER across the hall here at Taylor Regional, and I decided that I wanted something different. I was kind of tired of doing ER. I had done it for a long time, since about 2010, and this was around 2016. So, of course, I had worked ER as a nurse too. But I decided I was going to leave and I was going to give my notice, and the CEO of the hospital actually got wind that I was leaving, and she actually personally came to the ER and asked me not to leave, and she offered me several positions. One of them was this hospitalist role, and one of the hospitalists actually came and sort of courted me as well. Dr. Rogers, he came over and said, "We're very interested in keeping you here." So we talked back and forth, and we were able to work a contract out. And so I started working as a hospitalist.
That's awesome. So what do you do to market yourself, basically?
In this role, there's really not much you do for marketing. But my wife is a nurse practitioner as well, and she has her own office, as you well know, over in Columbia. So one of the things that she does to market herself is basically through word of mouth. People sometimes even contact her on Facebook. It's just amazing how word of mouth really gets you business. And when people find out that you're in practice and that their neighbor likes you or their cousin likes you, and people actually sometimes will even message her on Facebook and she doesn't know who they are. They're like, "Can I come see you as a doctor?" You know, that sort of thing. So social media is a big thing right now.
Right, yeah.
It has been a big thing for a long time. But it's a great marketing tool for businesses, for companies, and for individuals who are trying to get going in this field. Just by letting people know. LinkedIn is a wonderful thing. I actually use LinkedIn. That gives you multiple contacts in a large number of areas.
Right.
And it sort of just gets your name out there so that people can find out who you are and what you're about and what is your skill set. What are you good at? You know, are you great at geriatrics? Are you great at ER? Are you great at pediatrics?
Yeah.
So I think those social media contacts are a wonderful thing, and that's just a great way to market yourself.
Oh, yeah. How would you describe your current practice?
I would describe my current practice, like I said, as definitely acute care because I'm taking care of ICU patients. I'm taking care of inpatient adults. We don't practice with pediatrics, which most hospitalists do not.
Right.
The funny thing is I carry my own insurance, and last year I discovered that even if I take care of someone, say they have someone consulted and it's someone who's on OB, and they just had a baby, so they're having chest pain. I actually have to have an OB rider added to my insurance, or I could be sued, even though what I do
Really?
may not be related to what the problem was, which could be an OB problem. So it's really interesting that you have to have all of that
Right.
different coverage. So I added that to my insurance plan. But I definitely would say that there's a family. People don't really think that there's a family part of doing acute care, but I disagree with that. As I was saying, there is really a family aspect to what we do, even in the acute care setting, because we get to know these patients, and a lot of times they're repeat patients with CHF or chest pain, or they have a bowel issue, so they're coming in multiple times for the same thing. You get to know them, you get to know their family, you get to know their medications, and you just really, they become a part of your family, and you become a part of their family, and knowing what's going on. There's many times I go back to a room and I'll go, oh, hey, I didn't realize it was you. And I'm like, how's the grandkids? And they're like, oh, they're great. How are your kids? So you really get to know people personally. It's not always like that in acute care. But I think that when you work somewhere more rural like we do in this setting, you really have more of that aspect than you do in a big city.
Right.
So,
Okay. Next question's pretty similar. Just what is your job description?
my job description is basically I'm an in-house nocturnist. So I'm here from 7 p to 7 a, and I am responsible for taking care of everyone in the hospital that's on my service.
Right.
And to be honest with you, I'm actually responsible for taking care of everybody in the hospital, even the other physicians who may not have their patients on my service. If there's a need, then we're expected to step in there and do what we can.
Right.
Obviously, within our legal realm there.
So what's a typical day like? Like how many patients do you see daily on average?
Well, before COVID-19 hit, there were many days that I would be taking care of 40 plus patients here. But as everyone knows, as soon as COVID hit and then our numbers have dropped off, we're seeing right now somewhere around 15 to 20. I'm hoping that as we become more accustomed to COVID and it becomes more like a flu, maybe it's a seasonal thing, that we're going to see those numbers go back up. But I think every acute care facility has been hit pretty hard with numbers as far as their patient census is concerned. The other thing is with having added COVID to it, when you have these people come in who are exposed to coronavirus and have COVID-19 and they have multiple system problems, these people are very difficult to take care of. I mean, it's a lot of work, and it's a lot of keeping them stable during that time frame where they get bad.
Right.
So, and of course, the more systems that are involved, the harder it is.
Right.
So.
Okay. Let's see here. Describe the setting in which you work.
So basically, that's just this. I work in the ICU. I work in the ER. I work on the floor, med surge, and the telemetry floor. So basically, it's just all acute care at this point.
Right. Okay. Let's see. How do you fit into the organizational structure?
Oh my gosh, I don't really know how to answer that. The organizational structure. Well, I think the hospital as service, you have two integral parts here when you're talking about acute care. You have the ER side and you have the hospitalist side. Right. So I think as a group, we have to work together. Obviously, we all have to get along, and we have to get together to take care of the patients. So I think as far as where we fit in the organizational structure, the hospital is very dependent upon the emergency room and the hospitalist service to work together. So that we can have a good census here, because this is a business, and it's a business that needs to make money, and the only way to do that is to actually have patients to take care of.
Right.
We don't want people to be sick, but it is our business.
Right.
So I think as far as that's concerned, it's very integral that we mesh together, if that makes sense. And that's my mind frame when I'm at work, is I'm here to help them get the patient to the next step in order for them to move that patient out to have room for another patient to come in. because we don't want them to get backed up over there like that, because then that's a really bad thing for other people.
Right. Yeah.
So.
Let's see. How are you evaluated as an APRN?
We're evaluated every year, and what they do is the actual physicians that I work with, which is Dr. Frank and Dr. Hinton, actually are questioned about how they feel that I practice. Do I meet standards? Do I meet guidelines? They look at my H&Ps. They look at my discharge summaries, my progress notes. Am I hitting all the right points? Am I doing the right things, making the right decisions, ordering the right tests? It's really kind of a big thing if you think about it, because they're looking at CMS guidelines. Do I meet those? Am I putting Foley catheters in people who don't need them?
Right.
You know, because you can get into trouble for those things
Right.
with Medicare, because they have an expectation that you're going to operate at a certain level. So those people actually get together, talk about it, and they formulate my evaluation. And then I'm given the evaluation, and I have a chance to actually comment on whatever they've commented on.
Right.
And then, you sign it and move on.
Yep. Okay. So describe how you function using the APRN core competencies.
Well, and looking here, as far as direct care, consultation, and collaboration are concerned, it's just like I spoke about with the hospitalist and the ER. We all need to be collaborating together. We have to collaborate with other departments, physical therapy, radiology, lab, the surgeons. That's a really big thing, is being able to talk to the surgeon and give them a good report so that they understand what's going on with the patient, because they have to make a decision if that patient fits this environment. Because we're not U of L and we're not U of K, and so we can't really take everything that might come in the door, even though we would like to. We have to make sure that patient's a good fit for the services that we offer here. So collaboration and consultation are really big. As far as research skills, we're all doing CMEs all the time. I do CMEs. I feel like I do them every week. So I'm always looking at different research articles, trying to keep myself up to date, figure out what's changed and what's not changed, and you just do that on a continual, constant basis. Clinical and professional leadership, I'm really, really big on. I feel like in this position as a nurse practitioner, and I'm here at night by myself, and I have the whole hospital, I feel like it's really, truly my role to help lead the nurses where they need to be led.
Right.
If they have a question, I feel like it's very important that you don't put those people down. You don't belittle them. You don't talk to them like they don't know what they're doing. We all have questions, and I learn every day of my life. I learn something different. So I do feel like, especially in our role, that it is our job and our position to help lead and to help guide, especially new nurses, and especially with new nurses in this COVID era. And I know people are going to be speaking about COVID the whole time because it's changed our society in such a great way. We're now having nurses come out of school who haven't actually touched a patient.
Right.
Everything's been done online, and so they're very nervous, they're very scared, because you know how it felt the first time that you actually put an IV in someone. You're shaking and you're scared and you're nervous, so you really need someone to be there that has that leadership and has that support to give to these people so that they could be successful, because I want them to be successful like you were successful and I was successful. And so it's really important that we help lead and guide them, and we understand and stay calm and lead them in the right direction.
Right. Yeah.
So leadership is a huge thing, I think, with this role and this practice. And even if you're in an office, leading your front office staff, leading the people who draw your blood, leading the people, because they look to you for answers. When they step in your office and say, hey, I have a question, you need to be able to answer them. And if you're not, be honest. If you can't, you're honest and say, I don't know, but I'll find the answer for you.
Right.
And then so you're constantly and continually in a leadership role in this position every day and every minute that you're at work. It's really kind of amazing if you think about it. Because people don't think about being in that leadership role on a continual basis, but we really are.
You are. Yeah.
Because people are, they ring my phone constantly with questions and concerns, and how do I fix this? What do I need to do? What's the next step? So, we have to be ready for that. And I think focusing on leadership in school would be a great thing. You get a little piece of leadership. I don't know how things have changed because, again, I've been a nurse practitioner for about 11 years now. So it's been a while since I was in school. But I think leadership, I had a leadership class where they went over all of these things. So I think the focus on that, yes, exactly. The focus on that is wonderful because that is going to be a huge part of what you do every day. And you need to be prepared for that.
Right.
Let's see here. Coaching and advice, same thing we were just talking about. Ethical decision making. Wow, that's a big one right there.
Yeah.
We have to make hard decisions every day. But the way that I think about this is when I make a decision for a patient, is this a decision I would make for my grandmother? Is this a decision I would make for my mother, for my father? Where am I going with this? Am I doing the right thing for the patient, even though the family may disagree, even though people may be upset? If I'm talking to the patient and the patient's in agreement with the plan of care, then I feel like that's what we should do. We should always focus on the patient and what's best for them. And what I think may be best for the patient, they may disagree with.
Right.
And if they disagree, it's not personal. It's just they feel like that's not right for their life. So ethical decision making is a huge thing. But at the same time, I have told people, we have to do it this way. I know it doesn't fit your lifestyle, and I'm sorry, but let's make a bridge and let's meet in the middle.
Right.
Can we do it this way? Will that help you get to where I need you to be to get the best care for you and to get your health back to the baseline of what you're used to?
Mm-hmm.
So it's a huge thing.
Yeah. What about conflict management?
Oh gosh, that's a big one too. I approach conflict management the same way that I approach ethical decision making, because every nurse is not going to be comfortable with the decisions that I make, or every patient's not going to be comfortable with the decisions I make. But at the same time, I have to be willing to sit down and talk to those people and make a plan that's going to work. So if I'm dealing with a nurse and I'm having some conflict, I do my best to always sit down and say, this is what I think the patient needs. This is why I think the patient needs this. Tell me why you feel like this would not be a good fit. Tell me why you think this is the wrong decision. And then that way I understand where they're coming from and they understand where I'm coming from.
Right.
So that we can, again, build a bridge and meet in the middle to take care of the patient.
Right.
So you do the same thing with the patient. You do the same thing with the family. There's been many times that I have pulled a family out of a patient room and said, listen, they're not ready for what I'm telling them. Are you ready for what I'm telling you? Because this is what is really happening with your loved one.
Right.
And so, again, you have to sometimes defocus the patient and focus on the family, because they're going to be there to lead and guide that person. They're leading mom, or they're leading dad, or they're going to have a conversation and say, listen, we know you didn't want to hear that information.
Right.
You didn't want to find out that you have cancer, or you didn't want to find out that you have to have this surgery. But this is what we need to do for your health. So sometimes you have to use the family to get where you need to get with the patient. So you need to use every resource that you have, whether it's the connection with the nurse, or the connection with a grandchild, or the connection with a daughter or a son. So I think it's really important that we stop and think about actually including the family in the care, because I think sometimes people want to leave them out because they feel like they need to be focused on the patient and what the patient wants. Well, we are, but sometimes we have to have those people help us get there.
Right.
If that makes sense.
Yeah. Let's see. What about cultural competency, or how you use it in your practice?
Well, I actually did this the other day. I have a patient who is of Indian background. She was from India. She spoke no English whatsoever. So I knew I was going to have a hard time communicating with her. She was rather sick. She had congestive heart failure, atrial fibrillation. She'd had a heart attack. And here she is at our little rural community hospital because we couldn't send her anywhere else. We couldn't get her out that night. So we had to keep her here. So the daughter was staying in the room, but my fear was that I wasn't quite sure what their culture, if they would accept me coming into the room. So the first thing I did was pick up the phone, call the house supervisor, And I said, I need you to approach the daughter and find out, are they going to be okay if I come in the room and attempt to give her care or assess her or talk to her or look at her. And so that was because I wanted to make sure I didn't do anything that was going to culturally affect them negatively. Because the worst thing you can ever do is be the fault and make someone have a negative experience at your hospital. And of course, Dr. Reddy was working that night. So I called over to the ER while I was waiting on her, and I said, I need to know if you speak this lady's dialect, because if her daughter's not going to stay tonight, I need to communicate with her. And they had a belief where they didn't believe in using the phone system to communicate.
Wow.
So I kind of had a barrier there, and I was trying to figure out if her daughter's not here or something happens and she can't be here, because people's lives have, have things happen and she could have to leave. How am I going to communicate with this patient effectively? With her having AFib and CHF, anything could happen through the night. And here I am thinking, oh gosh, I'm not going to be able to even find out, is she having chest pain? What's going on with her? Is she short of breath? Because she won't be able to answer me. So he did not speak her dialect, unfortunately, but the daughter was able to stay, and I did find out that they were okay with me coming in the room. So you have to sort of pre-think those things.
Right.
And as soon as I found out about her, I was like, okay, I need to figure this out, because I wasn't sure. I really haven't taken care of anyone. It's my first experience taking care of anyone from India.
Right.
I've taken care of people from Saudi Arabia. I've taken care of people from Iraq, and they have a lot of cultural guidelines. As far as and that was when I was a nurse. And so, we chose not to make me her nurse. I knew not to go in her room that night, not to approach her, don't look at her in the eye, that kind of thing. So it's really important that we know and find out prior to something happening, because you don't want to be in that situation where you don't know what to do and it's an emergency.
Right.
So, so that's kind of how I use cultural competency. I always make sure that I'm sort of a one-up, a footstep ahead, if that makes sense.
That does make sense. What about challenges? What are your greatest challenges?
Oh, goodness. Okay. I'm going to be honest here, and I'm just going to throw it out there on the table. Because of experience, I think one of the greatest challenges that APRNs have, and it's because when we work in areas such as the emergency room, we're autonomous to a degree. But when you're taking care of a very sick patient, you may want to consult with the ER physician who you're working with, just to get their opinion, make sure you've made the right choices, the right decisions. Should I discharge this patient? Should I admit them, transfer them? Are these meds appropriate for this condition? That kind of thing. I think what's difficult for APRNs and PAs as well is we sort of have to learn to practice just like the person that we're working with that's sitting behind us, if that makes sense, the physician. So even in my role, even though I'm here at night by myself and I'm very autonomous, I'm very alone, and I just work by myself, I sort of practice like Dr. Frank. I'm a nighttime Dr. Frank. And I've learned through experience that you kind of sort of have to choose who you want to work like. Like, who does the things that are closest to where you think you should be in patient care. Okay? And so, not saying that Dr. Hinton does anything bad or Dr. Hinton does anything different. I think Brandon and I just coincide with our thought process and then the way we think about things, because I'll call him and I'll say, this is what I think, this is what I have, what do you think? And it's always, that's exactly what I would do. I agree. So you kind of figure out that, yes, I think like you. When I was working the ER, I worked a lot like Gary. I worked very well with Gary because we kind of think the same way. We're both very, I say non-traditional. Well, we're both traditional in the fact that we're conservative.
Right.
So, there's a very low threshold for admission. If someone needs to go in, we believe that's what should happen, even if it's just an observation for 12 hours.
Right.
If we feel uncomfortable with the patient going home, then we should be able to put that patient in the hospital. So I think it's hard, though, for some nurse practitioners and PAs to figure out how to change the way that they do things with each changing shift or changing rotation. Because as you know, over there, you're working with one doctor in the morning and one doctor in the evening, and you're sort of split. So, you know, you have to figure out, okay, it's okay if I do this with this doctor, but this doctor doesn't like it if I do that. So you know you have to sort of revert back. And so I think it's hard for some people to adjust like that and change how they're actually practicing. And I think that is one thing that's very hard for APRNs.
Right.
Is learning how to adjust your practice to the person that you're working with. To the person who's supposed to be guiding you.
Right.
You
That
know,
makes sense.
and always making sure that you're doing the things that they're comfortable with.
Yeah, that does
So-
make sense. Last one, what are legal or ethical issues confronting the APRN?
I believe at this day and time, and especially in this state, in the state of Kentucky, we're very, I want to use the word, uninhibited with how we practice, okay? To the degree that the Kentucky Board of Nursing recently even took away our need for a collaborative agreement because of COVID-19. So even if you are practicing day one in the state of Kentucky, you no longer have to have a physician sign a collaborative for you to prescribe drugs, which is unheard of.
Right.
That's never happened in history. And that's why I say COVID is changing our society,
Yes.
and we're having to adapt to the way that we're having to practice now. So, one of the things, we're so autonomous in this state compared to some other states. Some other states are very restricted in how you are able to practice.
Yes.
You know, APRNs were given the right to write narcotics earlier than anybody else in the state of Kentucky. You know, so we've been doing that for a long time. We were doing it before PAs were even allowed to do it. Some of the legal ethical issues is that we have to be abreast and know the ins and outs of everything that we do.
Right.
You know, writing that narcotic, making that decision because we can be so autonomous and even run a clinic without a physician now. So I've worked long enough now that I can practice on my own
Right.
with no one, you know, having no backup basically. It's just me out there, little old me. So I feel like we should all be abreast of those legal ethical issues that can become sticky, because there's some really sticky areas on like how you order certain tests such as MRIs or CT scans. And you know what, all of that's getting ready to change too as well. CMS is bringing down new guidelines where we have to actually go to a website, punch in what's wrong with the patient before we're allowed to order the CAT scan. And that website will tell us if the patient meets the criteria for the CT scan, the X-ray, the MRI to be paid for or not. And if it's not going to be paid for, then we have to make a decision. So that becomes an ethical thing, okay? If I know in my heart of hearts that you need this MRI, okay, or you need this CT scan, and it could be a life-threatening thing for you, and I get in this system and it says, no. Then I have to make an ethical decision. Am I going to go forward? Am I going to fight this? Am I going to call Medicare? And am I going to put forth that foot that takes all of that work to get done what you need to have done for you?
Right.
So there's some big ethical issues coming our way, and things are changing. And as you know, we become more narrow and more narrow in what we can do and order, especially in family practice, because everything has to be pre-certed. You can't just go, oh, this patient needs that MRI, I'm going to order it. No, it's not like that. Here in the hospital, we can do that right now until these guidelines come down. So there's a lot of ethical issues that I think, and of course, COVID-19 has changed the whole ethical picture. When it's a pandemic, is there really such a thing as HIPAA? Is there really such a thing as an emergency? Is there really so we have really had to stretch the way that we think and the way that we literally have had to step outside of the box. To get these people taken care of, and it's a crazy time, really.
It is.
And it's a changing time, especially for us old folks who have been doing this for a while, because I think we're a little more rigid, and you can't do that. And then you have new people come along and going, yes, we can. So, of course, there's legalities in everything that we do, every decision that we make. So I think just especially COVID-19 has changed things to a degree that it's almost confusing anymore about what we can and can't do in practice and how we take care of the patients, because it changes almost on a daily basis, because we learn more and more about this huge pandemic virus that that has affected the world. You know,
It's crazy.
none of us were ever thought. I never thought in my lifetime I would live this way.
No.
I thought maybe my children might, you know, as the future comes on, but it definitely has brought legal, ethical issues that we weren't prepared for.
Yeah.
So we're just having to adjust as we go and be flexible.
Yeah.
So.
All right. Well, thank you so much for your time. I
Oh,
really
you're welcome.
appreciate it.
You're welcome.